Thoracic imaging terminologies by a Fleischner Society guidelines. So I'll discuss some of the important terminologies discussed in these guidelines, and we'll try to review most of them. So the first is asinus. What is asinus? It is a structural unit of lung distal to terminal bronchioles. It is basically supplied by a first order respiratory bronchioles. It contains alveolar duct and alveoli. It is the largest unit in which all airways participate in gas exchange, and it is approximately 6 to 8 mm in diameter, and one secondary lobule contains 3 to 35 acini. On the CT scan, they are usually not visible unless there is an accumulation of pathological material, and they can be seen as poorly defined nodular opacities on the chest radiograph. Second one is ear bronchogram. So ear bronchograms, it is a pattern of ear-filled bronchi, low attenuation on a background of opaque ear, earless lung basically. As you can see in this figure, there's ear bronchograms as ear-filled bronchi. Next is ear crescent. It is a collection of ear in the crescentric shape that separate the wall of the cavity from the inner mass. As you can see, ear crescent, basically a collection of ear in a crescentric shape manner that separates the wall of cavity from the inner mass. It is often considered as a characteristic sign of either aspergillus colonization of pre-existing cavities or retraction of infarcted lung in angioinvasive aspergillosis, but more of a aspergillus colonization of a pre-existing cavity. Second terminology is ear trapping. So ear trapping is a retention of air in the lung distal to obstruction. So basically this is the part of the lung, air is coming down, being obstructed air. Now air is retained on this part and it's become more darker. And on the CT scan, basically it is seen on end expiration CT scan as a parenchymal areas with less normal, increase in attenuation, and lack of volume reduction. So there are more terminologies like ear space. Ear space is a gas containing part of the lung containing the respiratory bronchioles but excluding purely conducting airways such as terminal bronchioles. Then there is aortopulmonary window. It is a mediastinal region bounded anteriorly by ascending aorta, posteriorly by descending aorta, cranially by aortic arch, inferiorly by left pulmonary artery, and medially by ligamentum arteriosum, and laterally by left lung in pleura. So apical cap, as the name indicates, it is an apex of the lung which usually caused by intrapulmonary or pleural fibrosis, pulling down extrapleural fat. Architectural distortion is a terminology described as abnormal displacement of bronchi, vessels, fissures, or septa caused by diffused or localized lung disease, particularly interstitial fibrosis. We know atelectasis and collapse. It is a reduced inflation of all or part of the lung, could be because of obstruction, endobronchial neoplasm. Zygoesophageal recess is an area, it is basically in the right lower lobe of the lung. It is bounded superiorly by azygous arch, posteriorly by azygous vein, anterior to it vertebral column, medially by esophagus, and adjacent structures. This area is important as on a chest X-ray. You're not going to see any lesion if it's being there. It's not going to be displayed on a chest X-ray, so you might miss this area if the lesion is being here. And this area can be distorted because of subcranial lymphadenopathy or adjacent lymphadenopathy. It can distort this area. Then bronchocentric and bronchiolith, these are also two terminologies, self-explanatory. Halo sign is a sign, basically a mass or a nodule surrounded by a ground glass opacification. So let's do one BCQs in between. What is cyst? According to the Fleischner guidelines, it is a well-defined space surrounded by epithelial or fibrous wall. Ground glass opacification. So ground glass opacification, it is basically a hazy increased opacity of lung with preservation of bronchial and vascular margins. This word is very important. In ground glass, preservation of bronchial and vascular margins. There are numerous causes or reasons behind the ground glass opacification, but basically a partial displacement of ear is the main reason. It could be because of the pathology in the ear space, interstitial, or both, ear space and interstitial. It appears as a hazy increased opacity of lung, as I described, preservation of a bronchial and vascular margin. So first of all, whenever you find any ground glass, as you can see here, area of increased attenuation. You need to find out that is this is real, or it could be physiological, like patient is having a poor inspiratory effort due to age, or in a IV contrast CT scan. Next is consolidation. Consolidation is anything that replaces alveolar air, rendering a lung solid. There is an obscure of the margins as compared to the ground glass, in which there was a preservation of the margins. In this compartment there is an obscuring. But not necessarily consolidation always means infection. It could be occurs in cancers, as in this case disseminated adenocarcinoma, eosinophilic pneumonia, and ARDS as well. Next, honeycombing. So honeycombing is a clustered cystic ear spaces, typically comparable in diameter in order of 3 to 10 mm, but occasionally can be large as 2.5 centimeter. They are subpleural and they have a well-defined wall. the most important question comes, is it honeycombing or is it emphysema? So usually honeycombing, the walls are well defined as you can see in these CT scan. They're usually uniform, distributed, likely subpleural, involving 2 to 3 layers deep. But as compared to the emphysema, the walls are not well defined, they are not uniform and less layered. When we are doing honeycombing, let's revise the histopathological patterns and features of UIP pattern as well. So it is divided into UIP, probable UIP, indeterminate for UIP, and alternative diagnosis. UIP pattern is the pattern in which there is a dense fibrosis with architectural distortion, that is a destructive scarring and honeycombing. So architectural distortion is the most important thing. Location, where is it? It is predominantly subpleural, patchy, with fibroblast foci and absence of feature to suggest an alternative diagnosis. But if you find only one histological feature, but to an extent that preclude a definitive diagnosis of UIP or IPF, it could be a probable UIP, or absence of feature to suggest an alternative diagnosis, or honeycombing only. Other than that, it could be indeterminate for UIP. Fibrosis could be there with or without architectural distortion, but some other features are also present, and if it's other than that, it's an alternative diagnosis. So if there are predominant reticulations and some ground glass with the UIP pattern, don't forget that it could be exacerbation. So in exacerbation, both the patterns could be there. There are some other non-IPF, there are some other features which are non-consistent with an IPF, like upper zone predominance, mostly in HP, ground glass predominant, bronchocentric, ear trapping or mosaicism in HP, cyst or profuse micronodules. These are the features which are not consistent with IPF. Next is mosaic attenuation. So whenever the mosaic attenuation comes in mind, we know it is a patchwork of regions of different attenuations, high and low. First thing which comes in mind, is it an infiltrative process? Is it a small airway disease? Is it an occlusive vascular disease? To answer all these questions in mosaic attenuation, we need to find out what area is actually abnormal. Is that a black area which is abnormal? Is that a white area which is abnormal? To answer this question, look at the vessels in the black area. So if the vessels are less in the black area, I'll give some examples as well. It means that black area is the one which is abnormal. The second thing which need to be find out, is it a small airway disease or occlusive vascular disease? So if there is less vessels in the black area, look at the small airway signs. For example, airways are dilated, there could be a bronchiectasis which is representing to small airway disease, or occlusive vascular disease. If the airways are not dilated and there are no other abnormalities, then look at the features for occlusive vascular diseases, like look at the size of the pulmonary artery, if there is any thrombus, look at the ratio of RV, look at other features like pleural effusions. As you can see in this example, so the black area looks like there are less vessels in the black area, and there are some bronchiectasis as well. So it's more of a small airway disease. Same over here. This is the white area. This is the black area. This is the black area. So there are no vessels in the black area, and there are bronchiectasis as well. Dilated bronchioles. So more likely it is in a small airway disease. Let's check out the white area. When white and black both are abnormal. For example, look in this case. This is the black area and this is the white area. You cannot appreciate a vessels in both of the areas, and as you can see, some traction bronchiectasis as well. This is the black area, this is the white area, and in both you cannot appreciate a vessels. In that case, it is certain diseases which need to be ruled out, and like HP and sarcoidosis. When the white area is abnormal, and then it's more of a true kind of a infiltrative lung disease, and we are looking at a true ground glass opacification. This flowchart is very helpful whenever you come with a mosaic attenuation in which you are seeing high and low attenuation areas, black and white areas in the CT scan. Find out the vessels in the black area first of all. If the vessels are fewer in the black area, see the small airways. See the airways. There is any sign of a small airway abnormality, like direct signs, antilobular nodules, train bud nodules, indirect signs like ear trapping or expiration, then you know this is a small airway disease. If not, then it could be vascular disease, and find out how the heart is doing, how the peripheral vessels are doing, and if they are abnormal, this is the vascular disease. But if it's a uniform vascularity, both white and black areas are abnormal, then it could be a mix diseases like HP, sarcoidosis, RB, respiratory bronchiolitis, desquamative interstitial pneumonia, pulmonary capillary hemangiomatosis. But if it's a white area which are purely abnormal and having a few vessels as compared to the black area, this is a pure parenchymal disease, and they are pure ground glass opacifications. And white area is the abnormal area.